a buccal mucosa, floor, tongue, anything, even if the patient is coming for a dental reason. That is point one. But like sir said, if this patient is walking in with a complaint, then we need to get alert on what type of white lesion is it. From, let it be a precancerous to a cancerous. So I think, where is the white patch? Down, sir.
It's on the left buccal mucosa.
Okay, so white patch we need to identify between either it is a pure pre-malignant lesion, like we all of us know, it can be a regular leukoplakia which can be a homogeneous one, or it can be a erythroleukoplakia where the red patch is matched up. So first and foremost, diagnose it with clinical finding and palpation. Please palpate the.
So carry home message is any patch like this, do not neglect. The patient might have come for some other dental extraction, but if you see this, your antennas have to go up. Think of a leukoplakia. So Harish, what are pre-malignant lesions and pre-malignant conditions, Harish?
Yes, sir. First of all, I want to excuse me for having a bad voice of pharyngitis. Try to manage, but kindly bear with me. Like, sir told that today's agenda is mainly to see how can you help the community to make seeding better oral cavity. Just a glimpse of the data. According to Global 2022, there are around 36.7% of population of oral cavity cancers from our country. And out of which, more than 45% of death occurs in India because of oral cavity. The reason behind it is late detection. So the main agenda today is how to reduce these incidents so that we can save many. Like sir told very clearly, why are the problem? Updated for discussion on the so I want everybody to put hands together to detect the disease early so that we can see many lives will complete the smile to them. Now coming to the discussion, next pre-natal lesions are more concerned than condition because this lesion likely to be turned to invasive cancer in matter of time. So whenever you go for pre-malignant lesions, your thought should be how to treat that. Never put the patient under observation when you have lesion. But whereas in the case of condition, you have to put the patient under very strict surveillance. You have to take care of what to be done, what not to be done, when to come, when not to come, all to be enlightened to the patient. So like leukoplakia is the most common thing we have to see in our country in day-to-day practice. And likewise, OFMS and we can say lipoproliferative is also more common. So, yes. So coming to the.
This is the so-called leukoplakia, erythroplakia cascade. I'm just giving voice, rescue your voice, Harish. So this is what we normally see. From a normal mucosa to the spectrum. It is not a single condition. It's not like today it's leukoplakia, it will remain a leukoplakia. It's a spectrum that evolves over decades. So what you see as a normal mucosa over periods of time, it can become a homogeneous leukoplakia, a corrugated thickened leukoplakia, a verrucous papillary leukoplakia, a speckle leukoplakia, and erythroplakia. Each of these conditions has the more that towards the left that of the figure that you see, the risk is higher. So a speckle leukoplakia and erythroplakia have a higher incidence of malignancy. Now, what you see in terms of histopathology. Now, is the histopathology, you send a biopsy for this tissue, do you think the pathologist will tell you this is leukoplakia? No. Leukoplakia is a clinical diagnosis. Leukoplakia is a white patch which you rub off, it doesn't go away. So that is a clinical diagnosis. If your pathologist is giving you a report saying leukoplakia, it's time to change the pathologist. Number one. Number two is, so what do you look for in the biopsy report? The biopsy report not always comes with the report of in situ or invasive cancer when automatically the oncologist will get involved. Most often than not, this is what you'll find. Dysplasia, basal layer cutting, hyperkeratosis, and these sort of words. What you should be clear is, whenever you see the words dysplasia or basal layer hyperplasia, you should be careful. Because as long as it's a basal cell hyperplasia, you have the role that these will reverse. The moment the basal cell hyperplasia is crossed, you have dysplasia, you have to be very careful because it may not be reversible and they are going to a cascade where they can ultimately land up with a malignancy. Now, this is what leukoplakia is all about. Homogeneous leukoplakia, non-homogeneous leukoplakia. Supra, you will want to tell something about homogeneous and non-homogeneous leukoplakia.
And so, one small thing now, in that lesions and disorders now actually all have come under disorders. We don't separate, I think majority of the crowd will know that lesions and conditions are no more two separate things. We have clubbed everything under oral potentially malignant disorders. So remember that also. So this is very important. Why? Because homogeneous is something you don't need to panic about. And if an excision is done also, it's not that it is a totally wrong thing to do an excision, but in excision of a homogeneous leukoplakia, at least 50 to 60% of the time the lesion will come back. So don't panic when it is a homogeneous leukoplakia, but you can always biopsy and confirm. We are not against biopsy. But the moment it changes to non-homogeneous, that is a lesion with a white patch, where, as I said, red patches start appearing, please be more alert, because erythroplakia or erythroleukoplakia has much higher malignant potential compared to plain leukoplakia.
So basically this is what you do when you have a clinical diagnosis. It's imperative that one doesn't excise without a biopsy confirmation. For all you know, you may be excising, and if one margin is positive, you'll end up giving a lot of morbidity to the patient. So when you have a doubt, leukoplakia and erythroplakia, please do a small bench biopsy. Make sure you are dealing with an in situ lesion or a pre-malignant lesion or an invasive lesion, because the treatment is going to be different. So you can do it in many ways. You can do it with your scalpel, you can do it with your cautery, cryo, carbon dioxide. All roads lead to Rome, they say. So the treatment, you can use techniques that you are comfortable with, but remember that a biopsy prior to doing a major excision is always worthwhile. And whenever you have moderate to severe dysplasia, it is imperative that we tell the patient to stop smoking or tobacco chewing. No matter what you do, other than that, it is not going to reverse. Okay? So whenever it's mild to moderate dysplasia, there is a chance of reversal of this dysplasia in about 30% of cases. Okay? When it goes on to moderate to severe dysplasia, you are not able to reverse them. So it's imperative that we tell the patients, spend some time with them. Tobacco chewing and smoking, they have to quit that. Only then these sort of lesions will disappear. There is a role for the sort of supplementation with vitamins, which does help. But oral hygiene, addressing sharp tooth, okay, these are the things that are very, very important in this sort of situation. Erythroplakia, the risk is little higher. Harish, erythroplakia.
Yes, like you already told, these falls on the other side of the curve where pain should be managed with some intervention. We can't leave the patient on observation. Unlikely they will turn to invasive cancer, better we go yearly. And as I told, 40% of them turn to malignancy at any point of time.
This is the condition which we find a lot of Indian patients coming to us with. Okay, they are not something that you see in the West. They don't see this sort of lesions in, say, even in the Eastern Europe or in the eastern part of Asia. This is mainly because of the betel nut that is combined with tobacco. This squid that they keep, and this is responsible for submucosal fibrosis. You can make out here, it is like a white band. You can't miss this when you examine the oral cavity. Submucosal fibrosis. Submucosal fibrosis, what is the real worry is, this patient is lucky because you can see the oral cavity, mouth opening so good, you are not having trismus. You are happy as a dentist, you are not going to miss any problem. This patient comes with trismus, mouth opening is restricted, even if he has a dental problem, that is a nuisance. And this is a sort of patient where examination of the oral cavity itself is compromised and we may miss a malignancy. So it is imperative that in patients with submucosal fibrosis, they are put in a rigorous follow-up regime to make sure they don't go into trismus, and if they go into trismus, you should make sure that you don't miss any malignancies. Now, case number 2, 45-year-old gentleman, a tobacco chewer, presents with an ulcer of size 2.5 by 3 centimeters in the tongue of 3 months duration, clinically no significant nodes. This is the picture. And once you see this picture, I don't think there is no marks for diagnosing the condition. You know what is the diagnosis. So, now my question is different. Now we have all seen what is the diagnosis, what we are going to do. Now I would like a senior dentist like Sir Chandrasekhar sir is here. When you see a patient like this, sir, what will you do as a dentist, as a senior consultant, having seen when these patients present you with such sort of lesions? What would you tell the patients and what would you look for, sir? I want a senior person's opinion. Please, sir, panelists, excuse me.
Thank you. I feel I am sitting in midst of a World Pedagogical Conference. It's going to start next month. Now, as a role of a dentist, what I should say is, I would like to ask the question here. How many of you have seen an oral cancer case? This is a question I ask almost in all the conferences. And most of you people, students these days, you never get a chance to see a true oral cancer patient. Unless you see, it is very difficult to diagnose by yourself. Having worked in Cancer Institute for the past 20 years, I have seen cases which have been missed by the dentist. So there is a question which I would put like delay in diagnosis. See, when you get an ulcer, any ulcer for that matter, earlier days I myself, you used to prescribe a mouth gel, something like that. Next 3 days later he comes again, you keep doing it. And by the time that ulcer can transform into cancerous lesion. There is no saying when the role of a dentist, when he sees the oral cavity, say with the finger you just feel it, you will find the oral cavity, oral tissues gets conditioned initially. Conditioning means conditioned to your habits, whether it's a betel nut or a pan parag or some smoking or whatever it is. Slowly the tissue gets conditioned. And if you are able to catch at that particular time, warn the patient, you can stop the further, what they say as progression. Progresses. So first it gets conditioned, then it starts forming some other changes. And as sir has told about the histopathological changes, we need a pathologist, we need a microscope and so on. But clinically, how can you assess the progress of the disease? As in oral submucous fibrosis, when the patient is unable to open the mouth or put the tongue out, or all these are the small tests which you give to the patient. And you should coax them to leave the habit. The first thing is to stop the habit. So as a dentist, as sir asked me, when you examine a patient comes, you have to categorize into high risk or low risk. Suppose the patient has a habit, then it's high risk, so you have to search for whatever you want to see.